张念老师啊，算也是我老师之一了在海服是跟他学习的跟何敏啊，跟王志尧老师，大家一起来学习这个海服。因为最主要这个演讲是针对亚太地区来做这方面的认证的工作了那所以我想，在中国地方已经有很好的这个训练中心，那所以大概可能就是不是那么的适用我们今天要讲的内容。但是，我也跟大家一起分享一下，那这个我们的训练是怎么做的。那所以我还是用英文来做解释，让这个在亚洲地区、在亚太地区以及其他地区的这个同事们，大家可以来分享。好，那今天我的演讲就要讲 the necessity of the certification in the non and the minimally invasive gynecology therapy. And fortunately, I got the first international summit about 3.5 years ago, just here. And in that period, we got the memorandum with the ISMINIM and also the Haifu Hospital. And we have our trustee, that's the cooperation together in the training and also the accreditations in the non and the minimally invasive therapy. And so here will be our annual congress, just like in the 1990s in Chongqing. They have more than 3,000 participants in Chongqing again. And last year in Japan, 2021, they have more than 3,000 the Japanese doctors also there. Okay, so in last year's in Taipei, because of COVID-19 quarantine, so they also have 1,000 participants in this meeting. Also, our journals, GB official journals, include the Japan Endoscope Society and also in the Philippine Endoscope Society and the Taiwan Endoscope Society. That is an official journal in here. And we have very happy to declare they have a impact factor about 1.2 already in this recent announcement. So we know that we have evolutions, and we want to talk again in about the 19th centuries, the first generation surgery, open surgery, and now there's still a lot of the people have the open surgery, but more than 50% of the patients they have a change to second generation surgery. That's called the minimally assessed surgery, include the laparoscopy or thing called post surgery. And then when the 2005 began to have a robotic surgery and also focus on the function of preserved surgeries. So most of the doctors will think that will be the very important in the future, and since then we were into the end of the surgery. But the fourth generation surgery coming out include non-invasive and minimally invasive surgery, include the nose surgery and risk reduction surgery and HIFU, and maybe the IFA, and something just more and more non-invasive in the treatment. But Professor Long maybe had a talk just in the previously. He said that without trained lung or minimally invasive surgery may be a maximally invasive therapy. You know, even in the very simple anesthesias or very simple excision surgery, certain days will happen. But in the non-invasive surgery, not because of non-invasive, because you don't see the power of the sonar, you don't see the power of the radio frequencies. So if you not take care and take a training, lung and all minimally invasive surgery may be become a much invasive surgery. For example, that we have known lab 2 study that is quite famous. You know, in the major cancers, they treat with the laparotomy compared with the laparoscope by 1 to 2 the rate, and we can find after they can find in the patient receive the laparotomy, the outcome just the same as the laparoscope group. The 5-year survival have the 89.8%. And we don't say about the technique, the issues, but in our hospital, we can get 98% of the 5-year survival in the same time. They have a 10% difference between the lab trial and also in our hospital. So we can find they have a difference, but most of the difference is the number of the participants who change laparoscopic surgery to laparotomy will be 25.5% in this GOG study. But there is none in our hospital. So they're quite different. Not only these 5 years, also the conversion rate. We can also find they have because of the 56%, because of the poor exposures, and have a 50%, they have a cancer require laparotomy for the resections. And also they have an excessive bleeding in the 11%. So we can find they have conversion rate to 25% because of the poor technique or poor facility. If they can have a good training and accreditations, then I think the conversion rate should not less than 10%, and the outcome will be difference. And the next study Dr. Chen is doing about in the New England Journal of Medicine, the next study they found the low rate of disease-free survival and the overall survival in the 4.5 years survival versus the minimum emission is 86% versus the 96%. So they have a high rate of the local regional recurrence. So it means minimally invasive may be harmful for the cervical cancer treatment. But in our study, we have studied from 2009 to 2014 in China Memorial Hospital, and then we published the data on the Taiwanese Journal of OB-GYN. And we can find in about 69 patients, we have not so many cervical cancer now. So we get no recurrence in the past 5 years, and they have no recurrence, and the days rate just 0%. So here we can find the next study they have some bias, and because of the performance in surgery is not standardized, and also the standardizations of the radical surgery is not good enough. So this is in the cancer patients. But how about in the benign patients? In the postoperative, adhesions are associated with the major complications, and also the consequence of the adhesion includes lifelong risk. The survival in the cancer, but lifelong risk possible will be include the major cause of the small bowel obstruction. 74% of the adhesion related, and also up to the 40% have the chronic pelvic pain, and some of them have infertility, or 56% they need further surgery. So that is another complication. That is another question. So maybe we know they have some difference of the cause of the adhesions, but we find they have a trauma, or we can have make the infections, or they have a hemorrhage. So they make the patient have a suffer from the after surgery. Okay, so because of the technique, patient can get much more trauma because of the unsuitable holding the tissue. There was ischemic change, And if doing the sutures, maybe they have a folding body reaction, so make the patient have additional formations. And just like the lecture study, they get a lot of the hemorrhage, so they get a complication and outcome were poor in the later on. So in these situations, we can find the technique, the training, the certification is very important. So here's they have limitations in HIFU and endoscopic training. Just not like the Chinese interiors, they have a HIFU hospital, have a well training continuously. And in the other than China, maybe they have a limit, have a basic laparoscope and HIFU teaching during the resident and the fellowship. And also, the teacher, the tutor, they have even not any concept about how to teach or the concept of HIFU or maybe an endoscope surgery. So we said, if they can have such a successful in the HIFU hospital, maybe they have this can be have a success, can be copied. And so we just from the learning series, from very beginning, C1, do one, and teach one. That is the traditional the teaching the model. But we find if you just have a lectures, they just you can learn about 5% have a retention rate. And you can have audio videos, then they have a 20% of the retention rate. But you can have a practice by doing, maybe they have a 75%. So practice by doing is very important. And also, if you have an opportunity to have a teaching, then you can get 80% of the retention rate. So the page become a very important platform for every surgeon, every HIFU, and the endoscopists. So I think the learning theory we just obeyed. So it's not only for the lectures, especially very important in the practice in the endoscopist and also the HIFU, the surgeons. Because in the very beginning, we break down all the schedule, all the procedure to be at every step. And we build up and associated phase and make step by step review out. And then finally, we can use autonomous. So you know we can do it. But when we doing the 3D become 2D, you should need to visual spatial organizations because we see in the monitor that's just 2D. But in our concept, we can change this. We know the uterus in front and the cervix in the posterior, in the back. So we can identify the visual spatial organizations. So we will see even it's a 2D, but in our brain, we have changed to 3D. But it need to have a neuropsychological training. And also, when we do the treatment, we can find the forces that place just there. But somatosensory memory make us know that our left side have the forces in front, and the right side bipolar maybe in the posterior. So we using the hematosensory memory, we can do a good job there. And also we have a straight tolerance, ability to distinguish essential from non-essential ones. So learn series from surgical skills. RP training is based on the learning series. So that's why the RP joined with the ISMINIM. Why is the minimal invasive need to join non-invasive? Because the surgeon, they have the more instrument, more technique, with better, and to have benefit to the patient. So that is the reason that we have cooperation between RPH and the ISMINIM and also the HIFU and the National Engineering Center. And so how to learn in RPH? First, we have observations and the journal reading to familiar with the current trend in the endoscopes and also HIFU. And a surgical video editing and to familiarize with the surgical anatomy, surgical principle, and the surgical procedures. And then we have a drive and hand-on and animal lab under the standardized learning programs, and practicing a new advanced endoscope HIFU technique by the drug or animal workshop. So here is every year they have a dry lab in in Taiwan. We have a suture course and also the his course in the mother years. And also in Shanghai, they have the Shanghai MIT have an animal lab. And in Thailand, Dr. Alaya and also the Prof have the nose hands-on workshop in Thailand. They have the hand-on in teaching about how to do the surgery. And also the HIFU training have a basic requirement. First, they shall have a practicing license, and so they shall have a process PACE certification, and the stage of HIFU training, and the 3 stages of HIFU training. The overseas, the first, they will have a course of the HIFU. They have 4 centers in Hong Kong, Singapore, Taiwan, and the second stage, they will hand-on training with HIFU hospital in China, Chongqing HIFU, to assign the hands-on training center in China. And the stage 3 is attached to local practicing HIFU center. So we can find here, they have a headquarters of the training center, and I myself in here, and Dr. Wang and Dr. Zhang Lian is tutors in here with me also. And so when you have complete training and you go back to local to have on-site training and a HIFU specialist supervise. So that is a very standard and a regular training there. So why we need the clinical fellowship training? Because not all the risk and the scenario can be similar in the animal lab, and we can have a comprehension training course in the standardized methods. So here's the comprehension training course symposiums, panel discussion in the HIFU. You can see Dr. Xin, Dr. Wang, Dr. Dan Phyllis, and Dr. Li Wang on here. And so the training program is flexible by at least 1 year for the minimally invasive and the non-invasive surgery. We hope every one of you become a proficiency in doing not only the endoscope but HIFU surgeries. And so we got the certification in the Xinanyan. The first hospital affiliate is the AMU, Southwest Hospital in China. Dr. Liang is also very famous, and the audit and our committee chairs, the burners, also here. So they have audit all the training program and also the training center. So we come to join the accreditation for our training centers. Okay, so we make conclusions. Training education is crucial for non and minimally invasive surgeons. Non and minimally invasive surgeons shall be independent as a specialist. And the accreditations of the centers, certification for the surgeons are fundamental for the patient's safety. Accreditation is a justice for a good surgeons. We shall start our accreditation process. And the international is the best, and the local will be the second, and local academic society at the least. And so here will be our annual congress in Singapore this year, 25th, 28th October, and also have the annual meeting in India in August 30th and September 1st. Welcome to Taipei. Thank you.